Hi, I'm Dr. Youssef. I'm going to be presenting to you this case of bilateral cataract extraction and intraocular lens implantations. Right lens is the Tecnis ZCBOO, which is a spheric lens, and the left eye is toric lens for correction of astigmatism. So the regular steps is I use fixation ring to fixate the eye, and I use 2.75 knife. A 2 millimeter self-sealing incision is done in the temporal part of clear cornea, just at the limbus, followed by injection of Endocoat, which is from AMO, which is a heavy viscoelastic to protect the cornea and inflate the anterior chamber, followed by the formation of Paracentesis. Usually it's about 0.8 millimeters in the temporal part of about 80 degrees to the left of the main incision. This is the new thing I'm using in this here, which is the Wallace Capsulorhexis Gauge. It's about 6 millimeters in diameter, which gives you a 5.5 millimeter diameter capsulorhexis. The reproducibility of the capsulorhexis size and location is important for your nomograms to fine-tune your refractive results. This gives me a really well-centered, well-designed capsulorhexis. That's 5.5 millimeter every time we do it, almost. This capsulorhexis started with capsulorhexis trota forceps, followed I don't use usually the cystotome except for the much younger patients where the capsule is elastic, but I use the trota forceps itself to open the capsule, and that's to complete the capsulorhexis. This is well centered, 5 millimeters, regular in the center of the pupil or the visual axis. This is the hydrodissection and hydrodelineation and nuclear rotation. When you do the hydrodissection, hydrodelineation, make sure you push the lens backwards a little bit to allow the fluid to come out, to avoid the capsular block syndrome, where the nucleus can block the capsulorhexis and bust the posterior capsule. This is the starting the phaco. This year we are moving with the Peristaltic Venturi pump, a dual pump from the Signature AMO machine. It's a very efficient one. This was a posterior capsular cataract, and it's very soft, so that you can see that the nucleus didn't take much time to remove. It's mainly removed actually by irrigation aspiration, and this is the epinucleus taken in a whole part, and then I try to end up with a V-shaped defect in the cortical material, where they can go in with the J-Cannula to do a second hydrodissection or the cortical cleanup at this stage. The J-Cannula is very effective in this, and it's very safe. You use a 10 cc syringe with filled with BSS, and you just irrigate all the cortical material out, and it's very safe, very effective, and it can actually clean even the areas that you don't see. Much safer than the irrigation aspiration using the IA. Well, you do the IA afterwards, but at this stage we just use the J-Cannula. I'll do it after we implant the lens. Now the lens will be protecting the capsule, so it's much safer. So the capsule is cleaned up. Even the smallest lens material is out, even from the fornix. This is the heel on. It's a little lighter viscoelastic to inflate the bag mainly. And the lens in this side was plus 25.0 Tecnis ZCBOO, which is an aspheric lens. It's one of the best lenses available these days, and it's one-piece lens. And it's the curvature of the lens is designed so that it gives you better night vision. And at the same time, the square edge 360 degrees decreases the incidence of posterior capsular opacification, which happens frequently after lens implantations. You have to make sure that the lens is in the bag. This lens cannot go into the sulcus. It has to be in the bag. If you have any doubt, you have to make sure it's in the bag. And if it's not, you have to take it out and put the 3-piece lens if you have problems with the capsule or anything. You cannot implant this lens in the sulcus. If you do, you end up with chronic uveitis, pigment dispersion, glaucoma, and cystoid macular edema. So this lens cannot go in the bag, and frequently removed lenses that were mistakenly implanted in the sulcus, either any one of the one-piece design, either the Alco and the AMO ones. That's one of the main indications to remove those lenses, done by other surgeons, and I have to deal with this complication. Now the lens is implanted very well. You can see it very well centered. The Capsulorhexis is excellent size, covering the 360 degrees of the lens, and it's well centered, keeping the lens in place. The wound hydration, I use BSS for the center of the wound, and I use the Avelox, which is a fourth generation quinolone, to hydrate the wounds on the sides and keep a depot of this antibiotic into the sides of the wound. And of course some of it goes into the anterior chamber to be intra-cameral. So it's intra-corneal and intra-cameral Avelox, which decrease the incidence of endophthalmitis. My endophthalmitis rate for this with this technique is maybe about 1 in 5,000, 2 in 10,000. Surgery went very well. We do bilateral simultaneous, so that we are done now with this. This eye will change everything, and as if the new patient is coming in, and we will be ready for the left eye. Left eye is a toric lens, so she's already marked the cornea for the axis of the astigmatism, so you don't have to do any intraoperative marking. This is what we use. This is the Davis one step, the Mastel from Mastel, and it's that's how we mark the cornea with it, and it leaves a nice mark, and it gives you a 5.5 millimeter rexus together too. So that's how it looks, and I used it for this case. You will not see it clearly in the video, but it is there. I had to wash the xylocaine gel from the corneal surface to be able to see it at the end of the surgery. You see me doing that. So that's the left side. We'll start the same steps. This is again the 2.75 knife, 2 millimeter deep incision, followed by injection of the endocoat. I like the endocoat. It's heavy enough to protect the cornea, protect everything, inflates and stays in for the length of the surgery, and have to remove it at the end of the surgery. My corneas are very clear the first post-op day, actually immediately after surgery. I see my patients the same day after surgery, so I'll do them in the morning and I'll see them sometime in the afternoon, and the corneas are crystal clear. This is again the Wallace Capsulorhexis Gauge. I center it around the light reflex. I ask the patient to look at the light, and I center around the light reflex. Sometimes while you're doing the rexus itself, you have to modify the location of the rexus a little bit. I have what you see me removing here is the xylocaine gel from the cornea. When I do the Wallace Capsulorhexis Gauge, sometimes it forms a bubble and I have to remove it to be able to do the capsulorhexis. So this capsule is started. I just trace the mark that we already done on the cornea, and sometimes I have to modify it a little bit. We want to have a 360 degrees coverage of the edge of the intraocular lens. If you don't have that, this capsule will opacify. So this is the best way to avoid the posterior PCO, or the posterior capsule opacification. The hydrodisection again, and then hydrodelineation and nuclear rotation. Nuclear rotation in soft cataracts is not easy because the lens doesn't resist the movement, so it cannot move easily. But you don't have to do a lot of rotation for those soft cataracts. Sometimes you just do the hydrodissection, hydrodelineation, and you just remove the lens in place without having to rotate it too much. So again, the phaco done with AMO Signature dual pump, the Peristaltic Venturi. It's very efficient, very stable chamber. You'll find it working very well. I don't have any problems with surge or anything like that. It's an excellent machine. Again, the same steps of the surgery. You still try to divide, chop the nucleus, which is very easy because it's soft. Hardly using any phaco power to remove the lens material. Again, the epinucleus comes out. Always when I have when I'm removing the last parts, I'm always having the chopper underneath my phaco tip so that I avoid surge of capsule rupture. Now I'm doing the V-shaped removal of the last parts of the cortical material to be able to put the J-Cannula and do the second hydrodissection using the J-Cannula or the cortical cleanup. While doing that, you have to make sure that the irises doesn't get sucked, because usually very close to the iris, and you put the chopper to protect the capsule. Now again, the J-Cannula, you have to inject really hard to be able to clean up the capsule very well with the J-Cannula. You can see the cortical material is going out, and this is real speed, so it takes a few seconds to do a complete cortical cleanup for the lens. And actually, after implanting the lens, there's no much cortical material that need to be removed. It's just the you just need to remove the viscoelastic and center the lens using the IA at that time. It's done. We'll inflate the capsule with the heel on, and this is remember, this is a toric lens, so I'll have to position it on the axis that I already marked. For normal lenses that's non-toric, I usually implant it to be vertical in orientation, so the haptics are superior and inferior. This is the best centration for the lens. For toric, of course, you have to put it on axis. So this is the lens going in. I use the chopper to fixate the eye. I don't use the Sinskey or the Lester because I want to use the least instruments that are effective for the job. So the lens has gone in, and now it's in the bag. It's opening. Here, just position it as much as possible on axis, just short of the axis. The nice thing about this toric lens is that you can rotate it clockwise or counterclockwise because the edges of the haptics are smooth, so you can actually rotate the other way around. I'm washing the xylocaine gel from the surface of the cornea to be able to see clearly the marks I made in the preoperative room. So I'm doing the irrigation aspiration to wash out mainly the viscoelastic from the anterior chamber, and if there is any cortical material outside the lens, we'll remove them. This case was a dense posterior subcapsular cataract, so actually you might not see it on the video very well, but there is some posterior capsule fibrosis that I don't usually try to struggle with or try to clean it up too much during the surgery, because frequently if you try to do that, you end up with PC tear, and actually it doesn't affect the vision that much. And if you need to clean it up, you can clean it up with YAG laser in a controlled fashion after surgery. Usually do that maybe 6 weeks after surgery, not less than that, before they go ahead and change the glasses if they need glasses. For this patients, and a lot of patients after the premium IOLs, they don't need much glasses after surgery except for reading, and some of the premium, if you do multifocal or monovision, they don't even need glasses for that. So the lens is on axis. That's not 94 degrees. And now I'm doing the wound hydration using BSS, the central part of the wound, and I'll do the rest of the wound hydration and intra-cameral injection of Avelox after. Again, I'm trying to center the lens very well to be on axis and in the center of the rexus and cover 360 degrees all around the capsular axis. The wound hydration with using Avelox, it causes the cornea to whiten for a few minutes, and actually when I see them after surgery, I see them again the same day, sometimes within a few hours, and the cornea is crystal clear. There is no whitening at all in the cornea. This is because of the pH of the Avelox is about 5.6 on the pH scale. I'm trying to remove here. I'm trying to inject some of the Avelox behind the lens to try to clear up the fibrosis as much as possible, again in very controlled fashion after we implant the lens, so that we make sure that the lens is already in place. Even if the capsule opens, the lens is there to protect it, and you don't have to do anything even if you develop a PC tear at this stage, because it's already protected. The surgery went very well, well centered. And this is the post-op results. As I saw 6 hours after surgery, the hardly plano, and there is 20/20 in the right eye, 20/25 in the left because of the PC fibrosis. She's very happy. I saw her the same day. She can go back to work the second day. Thank you very much for watching.